treatment, all of these things, and introduce a fantastic new resource that we just released. All right, so my disclosures, I was a member of the Colorado Cures editorial board for the OBGYN section, and I am a member of the Baylor College of Medicine faculty, and all my opinions are all my own. Okay, so I'm going to introduce you to this, what we call the Colorado's Cure Project. So in 2019, a bunch of different organizations led by the Colorado Hospital Association, the Colorado Medical Society, and the Colorado Consortium for Prescription Drug Abuse launched this initiative to try and bring together all sorts of different specialties to get some best practices for the whole of the medical community. And what has resulted from that is a series of guidelines that are available online to everyone. These are not behind a fire or a paywall, that you can access about best practices in opioid prescribing across the spectrum. We just released the OBGYN guidelines, yay, in April, and these are specific to our patients and to our population. So for all of you that are doing projects of some way, shape, and form, these are there for you. Now the entire document is 184 pages. I don't anticipate you're going to sit down and read that, by the TV at night. But if you've got a project specifically focusing on something, looking at each of these sections is going to be helpful. So I'm going to outline some of what the sections are and just make you familiar a little bit with this resource for you. So brief overview, okay, it's broken down by 3 kind of sections, which is limiting opioid use, multimodal approaches to care, and harm reduction. But it is comprehensive for all sorts of different patients, hospitalized, obstetric, outpatient, all of those. And at the very end, there are some policy and practice recommendations to use. There's patient handouts, educations, and then some ways we can advocate for change. And the biggest thing and the huge benefit of this is not just from OBGYN primary literature. This took in evidence from anesthesia, from general surgery. We worked with our dental colleagues, our pharmacists, to really get a comprehensive guideline from everybody's best practices. So table of contents, you can peruse this. It is included. There's a link to it so you can see, but you can also Google Colorado Cures and it'll come up. But if you're doing a presentation like this one, there's tons of graphs that you can borrow and you can look at the most recent data in OBGYN, the most recent data in Colorado. And this just underscores the importance of the work that everyone here is doing. These are broken up, so you have key elements of systems. So if you're trying to implement a new ERAS protocol, if you're trying to figure out which populations you should target, these are all in there. And then it's going to give you some options for changing practice to do better in terms of limiting opioid use. These are just what some of these guidelines look like. There are links throughout the entire document to millions of resources. There's like 12 pages of references. So all of these things that give you some best practice guidelines if you're setting up new programs. So here's the link. All sorts of great stuff in there. Fantastic resource. Please, 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 please use it. Particularly relevant for Colorado, there are some sections in the anesthesia guideline on anesthesia considerations for cannabis use. So check that out. It's very eye-opening. All right, so I'm going to kind of use this through the lens of this new resource for you to talk about some of these best practices for you. So the multimodal pain section goes through surgery-specific guidelines. And I figured for everybody here, the most relevant one would be to go through our Cesarean guidelines. So ERAS, if you're not familiar with it, yes, enhanced recovery after surgery. I know many of the Colorado hospitals have already implemented this, but this gives you information about where this came from, why we're doing it, how we assess if it's working. The Cesarean protocol will go through all sorts of things. It'll go through pre-operative considerations. So what medicines do you give pre-operatively to these patients? What could you give? How do we change practice to reduce pain after these procedures? There's going to be a section that is going to then go over intra-op. So what can we do? Do we have anesthesia's ability to do tap blocks for patients that have higher pain tolerances or didn't get good pain relief from a past procedure? Are there other options that we can do? It's really funny coming down here to Baylor. We actually do tap blocks for all of our C-sections, which is a new protocol for me, but it is part of their protocol to try and reduce opioid use. They give you recommendations for post-op. How can we schedule our pain medications to reduce the use of opioids, including both Tylenol, ketorolac, but also opening up to things like lidocaine patches, which many of us aren't familiar with using. And then they give you some options. So when kind of what you're used to using isn't working, or if you're allergic or something like that, we have other options, and what could you use? This is for discharge, so it gives specific discharge recommendations. How do we continue a good pain regimen when people are at home without being our primary prescription reliance on opioids? And then each of the sections has a special consideration. So this is particularly for our opioid dependent patients. So this is for pregnant patients that have opioid use. What are we going to need to do to adjust them so that their pain is controlled, but that we're also not interfering with their maintenance therapy, that we're really doing patient-centered care here. So brief overview, very good information, very detailed, great resource for anybody looking at a specific procedure in these. So these are the detailed pathways that exist for OB. We have first trimester miscarriage, labor and delivery, post-vaginal delivery, and C-section. For GYN, we have chronic pelvic pain, vulvodynia, dysmenorrhea, and ovarian cysts that are specifically laid out as I've gone through them. The second section is on harm reduction. So many of you are familiar with a lot of these. We talk about, kind of trends in OBGYN. There is links to all of the treatment or drug drop-off centers, so for safe drug disposal take-back programs. But really, we as providers should be doing these things. We should be trying to reduce bias and stigma. And I know that we heard that earlier, that we have to battle our own biases first in terms of who is an opioid user in pregnancy, because it's not who many of us have preconceived notions about. We need to work on preventing overdose, so going through naloxone prescriptions, providing fentanyl test strips to make sure that if people are going to use, they're doing it in the safest way possible. Dose education. We need to talk about, after a successful period of sobriety, or non-use, they can't go back to using a dose that they were using before, right? They're more likely to overdose, and we need to keep people safe. We talk about routine infection testing, and that's for both sexually transmitted infections as well as associated use infections. So based on the mode of how they're using medications, we need to make sure that we're taking care of that. And then we need to take basic care of these patients. We need to refer them to treatment, mental health treatment, take care of that. We need to have the conversations about, if their prescriptions or their opioid supply is not from a prescription, how are they getting it? Are they trading sex work for these opioids? Are they in a situation where they're experiencing intimate partner violence, or are they a victim of trafficking? And how do we identify and help that? And then, of course, just making sure that if they are using injection for these opioids, can we get them into needle exchange programs? Or there's been a lot of discussion about some of these safe injection sites as well. And then really the bulk of what I want to focus on is really this focus on treatment of opioid use disorder. So opioid or substance use while pregnant, first we need to identify it. And it looked like some of you have some ongoing fantastic projects on how do we identify this, right? How do we screen our patients? You guys just had a fantastic talk on, hey, maybe, just urine drug screening is not the way that we should be screening these patients. But what else can we use? So there's some validated screening that you can do. It sounds like a couple of you are working with the SBIRT, the Screening and Brief Intervention Protocol, which is fantastic, supported by ACOG. But don't forget, you also need to screen for things like tobacco and alcohol use, and screen for coexisting mental conditions. And then it is recommended in the second, third trimester to rescreen. Right? This may be a new problem. This may be a coping mechanism for the stress of pregnancy, but more likely this is something they didn't feel comfortable disclosing to you in the first trimester, right? And so rescreening, they may be more comfortable with you as a provider, with your a way that you approach their care. And most importantly, it is not too late. It is not too late to get these patients into treatment. We really have to be respectful of care across the diversity spectrum. SBIRT is really good about this, but these are 6 principles of trauma-informed care that we need to pay attention to. We need to make sure that patients feel safe, both psychologically and physically, that they view us as being trustworthy and being transparent. You know, we have to tell patients, hey, we're going to screen you for alcohol, drugs, smoking, right? This is why we do it. We have to engage their support network. We know that folks that go home and have support at home are more likely in every single treatment aspect for all chronic diseases. Diabetes, high blood pressure, they do better if they have someone at home helping. And we really need to collaborate with other providers. Most of us are not experts in treatment of substance use disorders. And so we need a treatment team that is, we need a labor and delivery team that is, and we need to make sure that we are communicating well with those teams. And then we really need to empower patients, right? In this area, it's very common to come from a we know better than you perspective, and you have to do X or you have to do Y. And the reality is that you're sitting with an autonomous human that can make their own decisions. And they may not be the decisions that you would make, but it's not our place to judge those, right? We need to support them where they're at and really make sure that we're giving their voice power. And then, especially in OBGYN, we have to be very careful about the cultural, historical, and gender issues that we have. OBGYN has a history of excluding populations for good care. And we need to recognize that when they come into our doors, you know, particularly our Black and African American population, they don't trust us, and for good reason. And we need to check our biases, but we need to understand that they're going to have some hesitancy coming forward. And so we have to be really aware of that. Now, there are some patient handouts included in here that are fantastically helpful for prevention or for helping, you know, to try and assess how at-risk people are, keeping things safe. These are all fantastic. There's also screening tools. So if you decide that you want to use, instead of the SBIRT, some of these other screens, those are included. But the main point is to have a protocol, right? Pick one protocol that it works for your institution that you can use very easily. And then we have to treat, okay? The recommendation from the American College of Obstetrics, Obstetricians and Gynecologists is medication-assisted therapy is the mainstay of treatment, okay? We don't recommend withdrawal in pregnancy. People get too unstable. We don't recommend that. And depending on how the patient is doing, when you identify this as a chronic medical trouble for them, depends on how you can get them into treatment. You can do outpatient treatment. Even in pregnant patients, they can be started on maintenance therapy as an outpatient. And many, many places are moving to outpatient therapy, particularly in the first trimester. And particularly if they've already gone through withdrawal with buprenorphine, they can do that as an outpatient. And actually the recommendations on buprenorphine, you can do outpatient starts even in the second and third trimester, right? Because they've already gone through the dangerous part of withdrawal. If you're starting methadone, it is still most common to have those start as an inpatient, especially in the second and third trimester. There's a resource down here at the bottom. If you are not familiar with your medication-assisted therapy clinics, you can find a clinic if you move to a new place. That is a comprehensive list there. Included are 2 different protocols. These are quick start protocols. There's one for methadone and there's one for buprenorphine. So if you're looking at how you might be able to accomplish a new protocol at your institution, this is a fantastic way to do it. So you can quick start in the emergency room. You are going to have to coordinate with your emergency room docs for them to give methadone in the emergency room, right? And so that may be part of your care coordination and part of your program if that's what you're trying to work on. I think one of the big things you have to really pay attention to with any quick starts that are inpatient is the hours of outpatient maintenance therapy locations. We have many locations in the Denver area, but some of them won't take new patients on the weekends. So if you've met someone on a Wednesday, they're not ready to go home till Friday, they're not going to see them on Saturday. They won't see them till Monday. And so is your patient really going to be able to get their methadone maintenance for the weekend? Maybe not. And so take into consideration whether when you're considering inpatient versus outpatient protocols, that life is different on the weekends and we have to account for that. Here's the protocol for quick start buprenorphine. The big thing with buprenorphine is you either have to already be in or through withdrawal. for buprenorphine to start, or buprenorphine can precipitate withdrawal. And so we have to be very careful. And it's been one of the reasons why the uptake hasn't been as quick in pregnant women. It is safe, it is an acceptable option, but the uptake hasn't been as strong because of that period of having to have a withdrawal. It is sometimes a little easier to use though for patients. So patients who come in on buprenorphine therapy, we do not need to change them to methadone. They can remain on that therapy. Okay, so how are pregnant patients with substance use different? The bottom line is they aren't, okay? But their chronic medical disease is different. This is different than a patient that comes in with diabetes. This is different than a patient that comes in who has high blood pressure. So you need to treat the patient the same way you would every single other patient, right? But you need to think about how their disease affects their care. So bottom line, addiction is a medical condition. It's not a moral failing. And we need to meet patients where they are. We have to infuse empathy and respect into their care. And substance use disorder affects all races, all socioeconomic groups. We cannot judge a person by what they look like to say, yes, you have a substance use problem or not, okay? However, the chronic medical disease, right, and the way we explain this to patients, their disease is centered in their brain, right, but it affects their entire body. This is a chemical trouble and a way that their body responds to certain chemicals. With this particular disease, relapse is common, but relapse does not make someone untreatable, right? If someone stopped taking their blood pressure medicines for a month, you wouldn't say you never get blood pressure medicine again, right? You'd restart them on their blood pressure medicine, and the same with this therapy. And with treatment, brain function, cognition become normal, okay? Adequate treatment is treatment for this. And we know screening is often biased, right? It's biased by provider bias and these misconceptions. We know that African American women get screened at 2 to 3 times the rate of white women, right? And for no other reason than the color of their skin. We need to fight those biases and why those screening protocols for everyone need to be universal and universally applied. We do see this more when we do urine drug testing. It does tend to test people who are of lower socioeconomic status over those who aren't. And so universal protocols, when you're developing them, are critically important. So when we're counseling, you have to be respectful. I mean, we've all heard stories of this terminology being thrown around the floors. Maybe we've heard it ourselves. We need to use the lessons that we're learning from our diversity trainings to say no. We need to intervene as bystanders and say, that's not appropriate terminology for my patient in this room. Here's the correct terminology, and I would appreciate it if you would not use that anymore. We need to stand up for these folks because maybe other folks haven't had the training that we have. So how is pain different in pregnant patients with substance use? Well, they aren't different from normal patients. They still have pain. They still have complications, and they may actually have more pain, and they may have higher rates of complications. And some of that is due to the bias we as providers have for them. They also have other comorbid conditions, right? But they have more medication interactions. So we need to be careful when we're prescribing medications for other conditions that they don't interact with maintenance therapy. Each of these patients responds to stress in a different way with different coping mechanisms, just like all our patients do. But in this particular disease, stress can be a trigger for relapse. And so we need to pay attention to that. How is anxiety different? Well, they experience depression and anxiety around pregnancy, just like all of our new moms and our new dads. They have anxiety about being a good parent. They have anxiety about the process of labor and delivery and newborn care, and they have breastfeeding anxiety. The disease, right, means that some of our anxiety medicines might interact, right? We know that these patients get reported to CYS or Children in Youth Services at higher rates for reasons other than their substance use. And they're not substantiated more, they're just reported more. And we know that newborns may require different care, different interventions, maybe NICU stays. You do need to counsel these patients. Breastfeeding is strongly encouraged, but if they have a relapse, right, then we need to have a cessation of breastfeeding for a time until we can get them retreated. How is labor and delivery different? Well, it's not, right? We still need trauma-informed and racially sensitive care. We need to pay attention to who they want in the room with them. We know that data in the African American population has supported that having a support person that's non-family, a doula, improves outcomes, right? All outcomes, healthy outcomes for mom and baby, that can be critically important in this population as well. They need good explanations of procedures. They need to know what you're doing, why you're doing it, and how it's going to be done. They need fetal monitoring. They need vascular access, just like everyone else. But their disease may make it difficult. They may need alternative coping mechanisms because the medications that you usually would use might interact, right? Or they may not want to take them. So we need to have pain plans in place. Fetal monitoring can be impaired by methadone and buprenorphine treatment. We see minimal variability more commonly, and we see lower baselines. And so we have to take those fetal traces into account. And vascular access can be more difficult, so sometimes we need to pre-plan that maybe we need an ultrasound for IV placement, or we might need to place 2 IVs in preparation in case one is unusable. All ways to keep your patients safe. So how can we help? Well, we can switch to using functional pain scales instead of numerical ones, right? Someone's 6 is not everyone's 6, and we know this from everyone that comes into labor and delivery. But using functional scales, today I can't get out of bed, versus, today I can walk around the room, is a better indicator for pain and whether they need additional pain medicines. We can do education on our NICU processes and treatments, what neonatal opiate withdrawal syndrome looks like, so patients know what they're looking for. We can encourage breastfeeding. This is commonly controversial, and it shouldn't be. Breastfeeding is important in these patients, and we should be helping them and providing lactation support. However, these patients might need some help. We might need to change their environment a little to decrease some sensory things for the newborns, and to make sure that we're following these guidelines. The new Eat, Sleep, Console guidelines have a lot of sensory things that we can do. So here's some different, our traditional kind of pain scales. But the functional pain scale really switches us to where is it? What type of pain is it? What is it preventing you from doing, right? And then we can use these to kind of gauge when we need them, these more numerical values. We know that NOWS is increasing. We've seen this in Colorado. There's our numbers there. We are still in kind of this medium to high range. And so we need to educate patients on what to expect. So here's your table of your signs and symptoms. I find this is really helpful to explain to patients that these are processes that are central to the brain. It's not, one thing. It is all of these neurotransmitters that are very complicated. And this kind of helps patients to understand exactly what's going on with each of the medications that they've been using. We have non-pharmacological treatments for infants. These are focusing on mostly the behavioral activities as observed. There's some scales that our NICU and neonatologists use to see if they need treatment, but really we're trying to move away from even treating infants as much now. So the Eat, Sleep, Console is something I like to educate patients on, that this is our primary way to treat babies, is to try and make sure that we're just giving them the comfort and the care that we would to try and reduce their use of medications, just like we do with moms. Patients are doing really well with these. We had really good luck when we introduced this at Rose for not having babies be in the NICU, but to have them be able to stay in their rooms with moms. This is what we can do on the nursing floor to help. We can control the environment. We can control how they're feeding. We can control their social integration. This is all for babies. But if you think about it, this is all really good for mom too, right? Who doesn't want to kind of relax in a room that's a little more quiet and a little, prepared for us? All of these can really help both the stress of babies, but also the stress on moms from those NICU admissions. So this is a soothing position for baby. There's a video on YouTube if you want to watch it. It's kind of hilarious if you haven't seen this. The pictures make it look really, strange, but it actually works like a charm. So if you ever have a chance to try it, it's great. So again, breastfeeding, beneficial, right? We actually have decreased severity of NOWS because yes, babies get a tiny bit of whatever mom is on in breast milk, but it's not nearly to the extent of what they were getting while they were inside. And this helps to have a slow withdrawal or a slow taper for babies as well. We need less pharmacotherapy. The infants stay in the hospital less. And we all know the importance of attachment particularly with these patients where their stress level is really high. And then we can't underscore the immunity that's conferred right now, especially with the infectious disease environment that we're in right now. So we do have some, best practices. We shouldn't have any other contraindications, such as infection that they might pass to infant. And again, if they have a relapse, we do need to counsel them that we need to suspend breastfeeding because we don't know the other substances that may have been, particularly in when our opioids are obtained from a non-pharmacological or pharmacy source. Here's some data on the numbers, how much is in breast milk. All of these studies, right, have shown that these levels are significantly less significant than we ever would think they would be in infants. They're not going to have really like any pharmacological effect, but we do detect them. However, codeine and tramadol, we need to be very, very careful with because those are actively put into breast milk and can cause lethargy in the infant. So here's the treatments for now. If you're interested, I put it up there for you as a resource. Again, we're really trying to get away from this. There are multiple other projects in Colorado right now really trying to reduce the use in opioids. There's a new program starting up to try and get naloxone in the hands of pregnant women. And so, thank you guys for taking on a lot of these projects, for being involved in them. When we all work together, we can really help to reduce this risk of misuse and diversion. So last piece I'll talk about is just advocacy. We need more support. We need some more support nationally. When we published this, we were like, get rid of this X waiver. It's going to be terrible. And then they got rid of the X waiver. Way. So you can use it. You still do have to file a notice of intent, which is basically an application that says I have the support and the resources and things to be able to provide this to my practice. And you are limited to 30 patients, but it is hopefully going to maybe break through that barrier a little bit to get some more providers to provide. And then, of course, we have these health data sharing policy issues. So we need to be able to share their care when they are experiencing substance use disorders. So here's a whole bunch of the other groups that we've worked with, great folks out in the communication, out in the community that we communicate with for all of our folks. And I will then pause there and open it up for questions.
Brandy, it's Jamie. I'll start with a disclosure. I'm not a clinician. Most people on the call know that, but I'm just thinking about some of the comments and conversation we've been having with some of the participating hospitals. I know your focus in the conversation today, the topic was substance use, but we're looking at substance use, anxiety, and depression, and comorbidities that exist. And there's been some conversation about like the best timing for the screening for those various diagnoses. And so do you have any ideas about, we're hearing people are challenged to try to screen for everything on admission, it's such a busy time. And there's different aspects of what we learn from the screening, specifically with substance use that might be different for treatment versus anxiety and depression. And I don't know if you have any like ideas or what you've seen work well, or maybe even not work well, as far as the timing of the different types of screening for different diagnoses and what that might look like in a labor and delivery unit, from admission to discharge. So if you have any ideas or comments.
Yeah, so I think that the bottom line for everything is screen often, and if you're not sure, screen again, right? So you can do these in multiple ways that are quick in your office. So you can do screens just on your computer at check-in. And that can be your initial screen. And then any positives can reflect what the nurse or the intake staff actually really lays out a full screen for. So you can do double layer screening. There are quick screens. There are 2 question screens that you can do. And then only if they screen positive, you jump to the next screening level. You can absolutely incorporate those. Google, actually, if you now Google postpartum depression, comes up with the screen for postpartum depression. They do the EDPS. And so if you think that, you have any patients who might have depression but aren't going to tell you about it, put that Google link in your prenatal materials. they can get the same score on Google. And when they come up with a score over 10, Google says, hey, call your doc. You might be experiencing postpartum depression. And so reaching outside of the box and really reaching where patients are at can be a good thing. A lot of offices have moved towards doing a two-step intake. So doing a nurse intake that's an hour long that all of the screens are gone over, and then having that first provider visit really to only talk about those screens that had pertinent positives on it, and to go more in depth and do your SBIRTs there. And so really it's whatever works best for your space. I think when you're talking about inpatient, right, it's hard, right? We're juggling 10 million things to do. The patient-centered approach always works well, right? Hey, are you concerned at all today about X, Y, Z? And then if you have a positive answer, say, okay, well, let me talk to you a little more about depression. I have this series of questions I'm going to ask you to determine how much of a trouble it is for you. And so you can kind of incorporate and triage that way. And then, when you're admitted your other 6 patients and you have time to go back and do the full assessments on the other ones, then go back and do those. And so just having some flexibility, but also just a plan.
Yeah, very helpful. One size doesn't fit all, right? It's
No.
situation, timing, circumstance. Sure. Thank you. Brandy, sorry to be the one asking all the questions, but I'm just thinking of things we've seen participants ask who might not be on the call today, and others might have the same question, but just maybe multitasking right now, as we know, many people are working today. I'm wondering, again, kind of thinking of the hospital setting, and you had mentioned about weekends, specifically for like MAT and other treatments, that did come up from some of our hospitals, that they're struggling a little bit with thinking about process that might differ weekday versus weekend based on resources. And so I don't know if there's, a solution to that, like, what would a provider do? Especially a lot of our clinics, or I'm sorry, hospitals might be in rural or frontier regions, and, resources are scarce as it is, but are there like hotlines to call? Are there things in place that you don't discharge the patient until there's a resource available? Or do you have any, thoughts around that too? Because I have seen that this whole, weekend, different staffing models, different access to resources that we want to refer for treatment to aren't available. And what would someone do in that situation?
Yeah, this is one of those where this collaborative team approach is super important. Because if you have a pharmacist on board and on your team and in communication with them, you can discuss other options for a 2-day dispensing of a methadone dose, right? So that you can discharge them on a Friday, they can take a dose on Saturday, they can take a dose on Sunday, and then get intake on Monday. But you have to have a willing prescriber, and you have to have a willing dispenser. And so those are critically important pieces. We certainly saw people boarding over the weekend, right? So where they would stay Saturday, Sunday in the hospital the entire time, even when stable and didn't have a hospital need. Working with your ER colleagues, I've seen it where the ER has been the doser. So people come in essentially for a scheduled ER visit, right? To get their methadone dose in the morning, they're dosed, they go home, right? And so, but you have to think about it ahead of time, and you have to have the whole team on board. And so I think with these patients, we really have to think outside the box. Again, I think with the buprenorphine getting a little more relaxed in terms of prescribing, we're going to have more of those prescribers who are willing to do a 1 or 2 day prescription to get patients through the weekend. Methadone's still a little challenging, but I think as we reduce the stigma and the bias around this diagnosis and this disease, we're going to see people who are more willing to help for those 1 or 2 days. But it is setting things up and making sure that everybody's on board.
I love that, having a plan, right? And working with pharmacist team, ED. I know Katie brought that up on previous coaching calls, is like engaging your emergency department, identifying providers that have that ability to prescribe or administer. So yeah, a team effort, like you said, collective, right, work, and we're here to help for that. So hopefully when hospitals do have questions, if there's, you know, anything that the collaborative and we as support can do to identify resources, make connections, either in the hospital or in the community. A lot of our hospitals that are participating are working on that community connections and warm handoffs. So I think that, you know, echoing what you said, like that's really important, kind of thinking through all of that in advance so we feel like we're prepared and have resources.
Yeah. And then I think you guys are going to get the slides, but I did include a bunch of slides at the end that go into a little bit of the multimodal treatments. So if you do have some of these processes working around blocks or tap blocks or things, they're in those slides as resources for you to just kind of quick reference. And then they are all in both our document and actually the anesthesia Colorado Cures document is also fantastic. So, I mean, they're all fantastic, but I found that one the most relevant.
Great. Any other questions from participants? All right, it looks like, as Katie mentioned, we'll get all Brandy's slides out as well. It sounds like there's some additional resources there that we didn't go into depth to for today, but very helpful information, Brandy. That was awesome. So practical. And the other thing you mentioned that I'll just kind of put a question out to the audience, no need to answer immediately, but Brandy, you mentioned diversity training. And I'm curious, we had worked with March of Dimes, just kind of look at some bias in maternity care, and that's all the buzz with many organizations is, how are we supporting that work and helping people acknowledge bias and then, break it down and really address that in the care of our patients. And so I'd be curious, feel free to chat in if the hospital you work with or for or represent, a lot of you go to different hospitals or numerous hospitals, but I'm curious if hospitals are doing some sort of equity training or bias training. We as a collaborative would love to continue to work with partners to get funding to be able to offer that free of charge to all of our participants. And I've heard some rumbling. I know Denver Health was able to get some funding for that specific March of Dimes bias and maternity care training. So they've got some plans, but just, if you have thoughts or comments, either your hospital is doing this or isn't doing this, or would you like some resources? Let us know, because, the more we can do as a collaborative to help support you with education, resources, and tools at no cost, we'll try to work really hard for that. So loving that it's on people's minds, but wanting to also make sure that it's actually happening, and that it's not a one and done, that we're really changing the culture and not just checking a box when it comes to training. Perfect. ACOG, ACS, AMA, NMA, all of the big orgs. Yeah, and I bet there are some online, some virtual courses, that sort of thing that are really, and it looks like MIC looking for some options. So again, think if there's anything CPCQC can do to help you identify those trainings, support you if try to get some funding if there's a cost, or direct you to some free of charge classes, let us know.
Yeah, and I actually have some great recommendations for those trainings. One thing we may do is there's a self-paced training that I believe the HRSA, or the Office of Health Equity or Office of Minority Health, has created. It's specifically about bias in maternity care, and it's free and self-paced. So I will send you all that resource, but one thing we're considering doing also for the collaborative is perhaps timing it so that we ask you all to do this self-paced training. It's 2 hours total, but again, self-paced. And then we could come together as a collaborative to discuss it. So that's in the works. We're thinking about doing that at our next learning session, which isn't until late October. But in the meantime, I'm happy to send that resource again. And of course, whenever I come across good ones, I'm sharing it with you all. But always feel free to reach out if you're looking for this, because I will direct you to the right places and give you pros and cons of different ones. And some are free, some are not. I have a good list of free ones. So yeah, if you're excited about that, we're excited to help you.
Yeah. And the other thing, I know we just have a few minutes before our Tough as a Mother video, but I also wanted to throw out, as y'all are thinking, hopefully some ideas are in your mind as we talk about small tests of change, right? Like not afraid of failure, but really trying something and seeing if it works. The other thing I would mention, the one element that is critical that I cannot say enough is including patients in this work so that we can get input. And as many of you know, we have an expert faculty group that involves folks with lived experience, specifically in the substance use disorder and recovery. And they are really helpful at providing just, kind of ideas about how to have these conversations, what questions to ask, how to make this meaningful, really make it a conversational screening, and really just insightful in that they're fearful. We talk about that a lot. There's a lot of stigma and how we overcome that. And so I would encourage you as well in your hospital settings to think about how to engage patients in this work. And so like I mentioned, it could be that one time, one patient, asking them or, informing them why we're doing this and why it's important. And if they would be okay with, giving you some feedback about the process and how they felt and the questions and that sort of thing, because the patient perspective is so important. So having patient partners will be critical for really implementing a solution in your unit that makes sense for everybody. So I would encourage you, and if you need help in that area, CPCQC was just fortunate enough to receive a grant fund to develop a family integration program. And so we're working on some formal training for patient partners who may want to participate, and then we would integrate them in all levels of our organization and our quality improvement work. So ultimately we'd have some resources for you to leverage, some patient partners. But I would advise you to, have those conversations at your hospital as well. Is, do you have a family engagement group? Do you have a strategy? And how could you start with just one patient, getting their input, and then really embedding that into the work that you're doing, because that patient partner is so important in this work. So reach out to us if you'd like some help in that area. Share resources if you have. I know people from SCL Health. I've seen the parent NICU group, and they are phenomenal. And parents do rounds, and they actually are the ones giving updates on their infants' progress and medical condition. And so it's really, really amazing, the work that's happening. So I know it's out there. I know that y'all are doing it. So share so others can learn from you, and you may need help. So reach out and let us know how we can support your patient partner engagement in this project as well.
I also wanted to ask, I know we've talked before about, having one of your action items be to connect with your ED departments or just other areas of the hospital to find out who in your hospital is that resource that typically does MAT inductions in the hospital. So I'm curious to hear from you all. Have any of you connected with those people in your hospital who can start MAT in the hospital? Have you had challenges connecting with them? Has anyone initiated MAT during an L&D patient stay, and how did that go, and what was your process? We'd just love to hear more about how that is going in terms of connecting with people in your hospital who already have the experience of MAT induction. And if no one has connected with their EDs or anyone else, we want to hear that too. We want to hear why. Is it a capacity issue? Like what is the barrier there to connect with people in the hospital who already are initiating MAT? Bueller.
We may start giving out gift cards for participation.
So that's the carrot, or the stick is we just start randomly calling on you.
No, we don't do stick with QI. Positive reinforcement.
Hey there, Katie and Jamie, it's Lisa Becker, and I want to give a shout out to Allison and Kaylin, who I was pleasantly surprised that when I threw out MAT training to our obstetrics group, 10 people jumped in. And so we are arranging a training with Kaylin's expertise. And so that will provide a provider at PSL, at Swedish, at Aurora, and also in one of our clinics to be able to initiate and continue MAT. So I'm super thrilled and grateful to all of the people involved with that.
That's awesome. Congrats. That will make a difference. I love it. Awesome. You can hear it.
And there are also some upcoming opportunities for other people to join. I sent this in the newsletter,